Welcome back everybody to our second week of Abdomen 1. So we're going to move on to a much smaller organ than the liver. You hung in there. Liver is probably one of the hardest ones. We're going to go to the gallbladder. Hopefully, fingers crossed, super duper easy. Alright? So gallbladder and ducts make the biliary tree. So we're going to kind of learn about it all as they cooperate together. So let's start out with the anatomy of the gallbladder and the ducts. So as far as embryology goes, there isn't really a whole lot that you need to know in relation to the development of the gallbladder or of the ductal components. Just for the fun of it though, there's this little, so when we're growing, we are a tube. Well, we're a tube when we're adults too, because we're a mouth and a butt. But when we're this little itty bitty embryo, we really are a tube. And this tube has a little widening and there's a stomach there. And then right below the stomach is where the hepatic diverticulum and the cystic diverticulum come off. So at about the 4th week, this is 4th week gestational age, so mom doesn't even barely know she's pregnant unless she's taking a test like every single day. The little wider tubey part of the stomach churns a little bit, and when that happens, it causes these little bumps to pop out of different parts of the rest of the tube. And so these bumps are then the hepatic diverticulum, and the hepatic diverticulum is going to turn into the biliary tree. So it's going to be our intrahepatic ducts, and then our right and left hepatic duct, and our common hepatic duct. And then the cystic diverticulum turns into the gallbladder, so the sac that holds the bile. So out of the embryology, honestly, guys, you don't really need to know anything. I think it's just kind of a fun fact to throw in there because we've been starting all of our lectures with embryology. Now, as far as the location goes, the gallbladder sits on the posterior inferior portion of the right lobe of the liver. So we don't really see the gallbladder in its entirety if we're looking kind of from that anterior view. Whenever you look at anatomy drawings of it, you'll always see this like little lump of gallbladder hanging out the bottom of the liver, and that's really true. It sits behind the liver. So it's better seen on the posterior side, and that's on the inferior portion. And if we were to remove the gallbladder, what we would see it's sitting in is called the gallbladder fossa. It's this indentation in the liver. Now when we're looking through ultrasound, it almost looks like the gallbladder is just one with the liver. It actually is sitting in this little groove within the liver. And that again is the gallbladder fossa. Now the gallbladder fossa is easily identified by locating the MLF, or the main lobar fissure. And remember, we can see that extending from the neck of the gallbladder, or extending from the gallbladder fossa back to the right portal vein. And it's this bright white echogenic line. It is one of our landmarks for the long right medial lobe picture that we take on ultrasound. As far as where the bile ducts sit then, we have bile ducts that are intrahepatic and extrahepatic, and we delineate those by the porta hepatis. As far as the intrahepatic ducts go, remember they are part of the portal triad, so they run intra-segmentally. And so with each bile duct, we'll have a segment of the portal vein, and we'll have a segment of the hepatic artery that runs with it. And again, remember these run into each segment of the liver. We then have the extrahepatic ducts that sit outside of the liver, which really is just the common bile duct. As far as relational anatomy goes, the liver and the gallbladder and the biliary tree all work really well together. The liver creates bile. The bile then is secreted into the bile ducts, and then it goes and hangs out in the gallbladder until it's needed. And then when it is needed, the gallbladder puts the bile out, and then the bile and the pancreatic juices work together to help us digest our food. And both of those juices are sent into the duodenum. So the duodenum, the pancreas, and the liver are all very close proximity to the gallbladder, and they all kind of work together to help us digest our food. Now, as far as the gallbladder itself, it's almost laughable how easy this is going to be compared to the liver especially. So we call it a pear-shaped organ, and it's divided into the fundus, the body, and the neck. that's it. That's all you need to know about the gallbladder anatomy, basically. So the fundus is, of course, a rounder part that sits dependently in our body. This is that little hunky thing that you can see sticking out of the bottom of the liver on pictures. That's the fundus. So that's kind of backwards from what we normally think. The fundus hangs down into the body instead of up into the body, kind of like the uterine fundus does. So again, the body, or the fundus, hangs down. The body is the main portion of the gallbladder, and then we have the neck where it starts to narrow again. The neck then is going to join right in with the cystic duct, but the cystic duct is part more so of the biliary tree, more than it is part of the gallbladder. Speaking of the biliary tree, we do need to learn the parts of that. This one is probably a little bit more complex, at least compared to the gallbladder. So first we have intrahepatic ducts. Intrahepatic ducts are the ones that are coming in from the microscopic caniculi, getting those little bits of bile, and then they're going to start to grow larger as they converge towards the porta hepatis. So we consider these the intrahepatic ducts. They have branches that are similarly named to the portal veins, so they're going to start to converge into those. And then the main intrahepatic ducts that we get then are the right hepatic duct and the left hepatic duct. And those are going to come together to form the common hepatic duct. And the common hepatic duct we still consider to be an intrahepatic vascular duct. When the common hepatic duct and the cystic duct join, they form the common bile duct. And that's the extent of the biliary tree. So let's take a little bit closer look at these pieces individually. So again, we have the intrahepatic ducts. Remember that they are draining from within each of the liver segments. You can't read these very well, but we have like the anterior branch and the posterior branch. So they are named similarly to the portal veins. Those then are going to continue converging together till we get to a right and a left hepatic duct. So the right and left hepatic duct then are going to join together to form the common bile duct. Or excuse me, the common hepatic duct. So right and left join together to form the common hepatic duct. The common hepatic duct then sits within the liver and it runs parallel to the portal vein, and it's going to be exiting through the porta hepatis. The hepatic duct then joins up with the cystic duct, and the cystic duct is actually kind of a really interesting feature of the biliary tree. So it's about 2 to 6 centimeters long, 4 centimeters on average. Don't need to know this, fun fact. But what it does, it connects the gallbladder to the common hepatic duct. And what's inside of the cystic duct are these little folds. You can kind of see them here. They're these little folds of muscle within this duct, and these are called the spiral valves of Heister. So there's a fancy name for you. Probably should know it. Bet it'll show up on a test or boards at some point. So spiral valves of Heister are found in the cystic duct. And then the cystic duct, they believe, is responsible then for allowing bile to come in to the gallbladder and then regulates how the bile is released when needed. So now our cystic duct and our common hepatic duct have joined together. We're now outside of the liver. We're extrahepatic. We have created the common bile duct. Now the common bile duct gets a little fancy at the distal portion of it. So remember, we create it by joining the cystic and the common hepatic duct. Those join together to create the common bile duct. It's going to course along towards the pancreas, and then it kind of pierces through the pancreas head and joins up with the main duct of the pancreas. So we have the common bile duct at the pancreatic head, and we have the main pancreatic duct at the pancreas head, and they're going to join together. And they join together right before they go into the duodenum. And there's this tiny little hole in the side of the duodenum, inside of the first small part of the intestines, that these are going to join together and enter through. So this little hole allows the bile to flow into the duodenum, and it allows the pancreatic enzymes that help with digestion to flow into the duodenum. And then at the end of this little hole, the hole is called the ampulla of Vater. We didn't get to that. So another fancy name, remember this name, ampulla of Vater is the hole that the common bile duct and the pancreatic duct empty into the duodenum. And then there's this tiny little circular muscle called the sphincter of Oddi at the end of it. All right, so there's a couple more names that you do need to know. So we have spiral valves of Heister. Those are in the cystic duct. We have the ampulla of Vater. That is the hole in which the common bile duct goes into the duodenum. And then the sphincter of Oddi, which is a muscle that controls the ampulla of Vater. So the sphincter of Oddi also helps to release and regulate the flow of bile and pancreatic enzymes. As far as vasculature for the bile duct, there isn't a whole lot that you need to know. We've actually already learned about it in the liver chapter. So we know that the aorta branches into the celiac trunk, and the celiac trunk will split into the splenic artery and the common hepatic artery. And then the GDA comes off, and that turns into the proper hepatic artery, or the main hepatic artery. Once the main hepatic artery enters into the liver, it branches then into the right and left hepatic artery. Only thing you need to know, off the right hepatic artery comes the cystic artery. And the cystic artery is the name for the vessel that feeds the gallbladder. As far as drainage from the gallbladder, the veins that lead away from the gallbladder just empty into the portal system. Pretty easy. All right, so our next few slides then are going to be about some variants that we see with the gallbladder. So the first variant is called Hartmann's pouch. And Hartmann's pouch is this little pocket right at the neck of the gallbladder. So it's almost as if the cystic duct is coming into the side of the gallbladder instead of connecting right in through the neck. So we get this Hartmann's pouch. And Hartmann's pouch has another name. It's called an infundibulum. And that's a fun word to say, infundibulum. So the kind of tricky part about Hartmann's pouch is that it can catch stones or it can get sludge within it, and then that can cause some extra problems for the patient. So again, it's just this little pocket that hangs off to the side of the neck of the gallbladder. The next variant is called the Phrygian Cap. And the Phrygian Cap is seen at the fundus of the gallbladder, so on the opposite side of where we were from the Hartmann's pouch. And the Phrygian Cap is this little fold where the little fundus of the gallbladder doops over, and that makes kind of what an old Victorian hat called a Phrygian Cap, this is what it's named for, had this kind of funny little fold over. It's like a Papa Smurf hat, almost. So our gallbladder is wearing a Papa Smurf hat. It's kind of just this little fold that pulls the fundus of the gallbladder over. Now, we'll talk a little bit about it when we talk about rolling our patients. The gallbladder is pretty floppy. Sometimes this Phrygian Cap will flop out a little bit when we roll them, but it's usually still pretty apparent. And these are pretty common to find. Our next variant then is a gallbladder septation. So as the gallbladder is becoming open and it's getting that lumen to it, the kind of hollowed out area, sometimes it just doesn't go the right way. And so we end up having these septations that come across. Now, from this picture, and I think this is where it's a little confusing from the pictures, remember we're cutting just a slice of this off, so we're seeing part of the septation. So it almost looks like nothing would ever get into these areas here. But remember, there might be some gaps in the 3D model of this that could still fill in these septations. But septations are just kind of like extra wall that's going through there. Not a big deal, very normal to find. The only thing that might cause some issues for people, if one of these septations has a very small opening, it might be harder for that bile to get out. And when bile sits somewhere for a long time, it is more likely to form sludge, which is just really, really thick bile, or it is more likely to create stones. So there is some downfall to having septations, but for the most part, people don't know that they have them, and they're usually asymptomatic and nothing critical comes of them. Another finding that we might see, and it's very, very rare, is called a gallbladder duplication. And a gallbladder duplication is actually just kind of a fancy septation of the gallbladder. So when this happens, you usually get two gallbladders. One of them is usually not functional, usually the smaller one. And this is actually something we can't diagnose by ultrasound. It's very difficult for us because we only see in that 2D plane, is it a true septation all the way across, creating that gallbladder duplication, or is it just kind of cutting across and it looks like it's a full duplication or full septation or a full duplication. So unable to diagnose by ultrasound, but it is very, very rare. I believe they need to have surgery to officially diagnose it. Gallbladder agenesis then is when the gallbladder fails to develop. Also pretty rare, but is associated with multiple syndromes. As far as the ducts go, we'll talk a lot more about this when we get into abdomen 2 and we start going through pathology. The more severe ductal variants are going to cause quite a bit of pathology for the patient, so I left it more for that chapter. There are some very simple branching patterns that change, kind of like with the hepatic veins where they can kind of join together in different ways and empty into the IVC differently. Kind of the same idea with these simple ductal variants. So they just join together in random ways and it's not really going to affect anything. In fact, it's not really even going to affect how we do our jobs. Most likely because where all these variants are, we can't see the ducts anyway. And that's it. That's pretty easy for anatomy. So let's get into what everything looks like by ultrasound. So first we have the gallbladder. The gallbladder, again, is a pear-shaped organ. When it is healthy and normal, it should be anechoic. Bile does not produce any echoes, so we should see black throughout the gallbladder, or anechoic. And then the wall should be very thin and echogenic. So this picture here, we can see the neck coming into the body, and then the fundus of the gallbladder. We can see that this is nice and anechoic, and we have a thin, bright wall around it. Here again we have the liver. This portion here is the duodenum, and the duodenum sits right next to the gallbladder. And this gets kind of tricky because gallbladder stones can hang out kind of on this side, and so now we're wondering, are these shadows from the duodenum or are these shadows from something that's in the gallbladder? So this kind of ends up being a pitfall of how these are related to one another, but that's why we roll the patient and make sure we look at things in multiple views. This then is a transverse view of the gallbladder. Again, it sits more to the inferior portion of the liver. So we have the inferior liver, we have the kidney here, and then again we have the duodenum coming across and the IVC below it. Now if you're scanning somebody very, very, very thin, their gallbladder and their IVC almost tend to sit on top of one another. And this was a really, really tricky part for a lot of students. They would be following what they thought was the gallbladder, but it was the IVC the whole way down. And so if it doesn't stop when you're in transverse and it doesn't stop, it just keeps going, you might be on the IVC. Worst or best case scenario or worst case, I don't know. Put some color on. Put some color on there. Make sure that you are imaging the gallbladder, not the IVC. They look very similar to one another. They both kind of take on these irregular shapes. So put that color on. Make sure you're following the correct organ when you're doing your sweep and when you're taking your pictures. The MLF we talked about when we learned the liver anatomy, but it's also helpful for our gallbladder anatomy as well. So here is the MLF. Remember, it's that bright echogenic line. Splits the liver into the right and left lobes segmentally. And so the MLF then connects to the gallbladder fossa back to the right portal vein. So again, that MLF is going to be very helpful, especially if the patient had their gallbladder removed. We do take pictures of where the gallbladder used to be in that gallbladder fossa, so we want to find that MLF as our landmark. Now the intrahepatic ducts are not typically seen by ultrasound. If we can see them, something abnormal is going on. So I don't want to get too much into what the intrahepatic ducts look like because this is very abnormal. We should not see ducts like this. But I did put this picture in here just to kind of show you. We have ducts that come in, they converge towards the porta hepatis. We have the right and the left duct, and then they're going to head out of the common hepatic duct. But again, this is very abnormal. If we do see ducts, they should be avascular. So if we put color on this, none of this would light up because the bile does not create enough flow change to create a Doppler change. And then the walls are typically very thin and a little bit brighter. The common hepatic duct then is the first thing that we can see of the biliary tree, and it's something that we definitely want to evaluate. So the common hepatic duct sits on the inside of the porta hepatis, so it's an intrahepatic duct. And when you're looking at your liver, looking at the bile ducts in long, you want to elongate out your bile duct, and then you want to look at where your liver is. So I see liver tissue here, and I see liver tissue here, and I'm going to kind of create an invisible line connecting these two with a little bridge. And anything that's on this side of the liver, this is going to be intrahepatic. That's going to be our common hepatic duct. If it's over here, then it's outside the liver and it's our common bile duct. So I think this picture is gorgeous. It shows us both really nicely. Again, we have liver tissue here. I'm kind of creating this imaginary line coming up through here. So now I know that anything on this side is the common hepatic duct, anything on this side is the common bile duct. This is another difficult distinction for students to make. So when you get into lab and you start scanning, ask your instructors. Point out, I think this is the common hepatic duct, I think this is the common bile duct. Am I correct? And they'll let you know, and you can work on getting your sonographer eye to that porta hepatis. So the common hepatic duct, again, on the inside, avascular, bright, thin walls, and then we usually see it running parallel with the portal vein. The cystic duct is another thing that we don't typically see by ultrasound. So if we do see it, something abnormal is most likely going on. This is just kind of a neat picture that shows a dilated cystic duct. And we can actually kind of see the spiral valves of Heister through there. We can kind of see these little filling defects. And so you can see those kind of coming through and then to the neck of the gallbladder. But again, we should not see this. We should not see the cystic duct. The common bile duct then is another very important organ that we need to elongate, that we need to see fully, but is tricky because there's a lot of gas from the duodenum, from the stomach. We've got the pancreas in there. There's just a lot of stuff going on in this kind of central area. So we're going to do our best to visualize the common bile duct from where it starts at the porta hepatis to where it ends at the pancreatic head. So this is a cross section of the porta hepatis showing us our portal triad. We have the portal vein, hepatic artery, and then the common bile duct. So this is called that Mickey Mouse sign. If we elongate out the common bile duct then, we can see over on this side we're at the porta hepatis where it begins. It's running fairly parallel with the portal vein and the IVC. And so we have it extended all the way out, and now we are getting into the pancreatic head on this side. So this is another gorgeous picture of the entire common bile duct. These are rare. These pictures are rare, but it shows you nicely what the anatomy is and what it could be in your pictures. This little dot right here with the arrow to it, that's the hepatic artery. So we consider the side that is down at the pancreatic head, we consider this to be the distal end of the common bile duct. I've worked many places where they wanted proximal and distal measurements of the common bile duct, so typically we'll take it somewhere closer to the pancreatic head. So like I said, there's tons of stuff going on kind of in this central area here, and we're going to learn more about this when we talk about pancreatic relational anatomy, because we use these landmarks to find our pancreas, because the pancreas is really hard to see. But we've got the pancreatic head here. We've got these two little arrows are pointing to the body of the pancreas. But what I want to point out is that there's this little hole here, and there's a little hole here. And the GDA, or the gastroduodenal artery, if we put color on this, should light up, and it's one of the things that come through the pancreatic head. The other black thing in the pancreatic head should be our distal common bile duct. So if you can go midline on trans, or trans midline, and you can get a beautiful pancreatic head, then you should be able to follow your common bile duct from that area. It's probably the way that I usually find my common bile duct. You'll be taught to do it this way or from the porta hepatis. Neither is wrong, neither is absolutely correct. You do what you gotta do to find the anatomy that you need to see. I have some pictures on two of the variants that we talked about. So we have Hartmann's pouch. This is, what is going on here? I think this is the gallbladder back here. Looks like there might be some sludge in it here. This is the neck coming down and around. So we have this little outpouching here. And what actually happens to be in this is a stone within that outpouching. Here's an example of that Phrygian cap. Again, the neck is down here, body, fundus, and we just kind of get this fold of wall here, and then this little plop over of the gallbladder fundus. This is an example of a gallbladder that is very folded. So sometimes when we roll these patients, they'll unfold, sometimes they get more foldy. All depends on how they're built. Nothing's right or wrong. We just want to document if we see anything other than normal. Typically with patients that have folds, I'll just write fold on there so the doctor doesn't think it's more than that. Sometimes they can just make the gallbladder look kind of weird. So if I see something like this, I would just write fold next to it after I confirmed that it was a fold. Here then is that rare duplicated gallbladder. So again, it's it looks duplicated. It's not suspected, but we just can't officially diagnose it by ultrasound. So we have that septation running through here. It's a full septation running wall to wall, dividing that gallbladder into two. Remember, one of them usually is non-functional. And then we have an example here of some septations. Remember, we're only seeing a slice of this, so there's probably some space for bile to move through these in other slices of the gallbladder, but septations usually will connect wall to wall in one direction. Now sizes, what do we expect to see for sizes? The gallbladder doesn't necessarily have a normal beginning size, like we know we have normals for a liver or normals for a kidney. The gallbladder, we just don't want it to exceed a certain size. So the gallbladder can measure up to 10 centimeters from neck to fundus. So in its longest plane, long to the organ. So up to 10 centimeters. It can also measure up to 4 centimeters in width. If it exceeds either of these measurements, then we call it hydropic. That's Hydropic, hydropic gallbladder. And that just means that it has a lot of extra bile in it. Now when a gallbladder expands past these measurements, we might be concerned that there's some sort of blockage somewhere causing the bile to back up into the system. So hydropic gallbladder, if it exceeds either of these measurements, over 10 or over 4, but it can get up to 10, up to 4 centimeters. The gallbladder wall then should not exceed 3 millimeters. 3 millimeters and more is considered pathologic. So we expect that gallbladder wall to be nice and thin. Another thing you need to know about the gallbladder wall, when you measure it, you must measure somewhere on the anterior wall. And I'll point it out when we go over the protocol. But you must measure somewhere on that anterior wall, never on the posterior, never on the side. You can see that we're kind of losing our wall here. We're not getting those clear defined borders. If you're looking for a place to measure and you just can't find a nice border, forget it. Either take your picture and move on and find a different picture to measure, or retake your picture to get a nice crisp border so you can measure. Again, never measure on the posterior side here, only on the anterior. When you see your protocol, you will be able to choose, do you want to measure in long or in trans? This is an example of what a patient's gallbladder might look like if they're not NPO. So we ask our patients, or the schedulers, or whoever is getting them put up for the exam, they're going to tell the patient nothing to eat or drink for 6 to 8 hours. And we have patients all the time that say, oh no, I didn't have anything to eat. Well, then their gallbladder looks like this. So then you have to stop and ask, did you really have something to eat, or is something wrong that your gallbladder is contracted? And usually at that point they'll be like, yeah, I actually had coffee with cream in it this morning. And you're like, okay, well, this test became non-diagnostic because now I can't evaluate your gallbladder. So NPO is really ideal for patients who are able to be NPO. You're going to have patients that come in from the ER, they just were at Kentucky Fried Chicken, they ate a bucket of chicken, and now their stomach hurts. They're going to have a gallbladder that looks like this. We do our best with it. But when you have the chance to prep your patient, it should be prepped. And the reason for that, let's see. You can see on this one, we can see the entire lumen of the gallbladder. We can tell nothing is in there. We measure the wall. Look, it's 0.18. It's beautiful. Everything's very normal. Well, what are we supposed to do with this? We don't know. Maybe a stone is hiding somewhere. Where do you measure the wall? Technically, it's just this bright part here. The rest of this is muscle. But it just makes it kind of yucky looking and makes it very difficult to create diagnostic images from it. Oftentimes when the patient does have a gallbladder that looks like this, I still measure it and put in there patient was NPO, and then the radiologist will put in their report patient was NPO, non-diagnostic for gallbladder, consider repeating if necessary. So there you have it, off my soapbox. As far as the biliary tree goes, the common hepatic duct should measure less than 4 millimeters, and the common bile duct typically measures less than 6 millimeters. But there's an asterisk to that common bile duct, and that's the Presbyductia. So as we age, it is expected that the common bile duct will start to enlarge, and it has a very specific enlargement pattern. So after the age of 50, it is normal for the gallbladder to increase by 1 millimeter per decade. So a 60-year-old with a 6 millimeter 6 millimeter common bile duct is okay. A 70-year-old with a 7 millimeter bile duct is okay. We expect them to get larger as patients age. The other reason that common bile ducts might expand a little bit is if a patient has had a cholecystectomy. Now, cholecystectomy is where the patient has their gallbladder removed, and so the common bile duct will kind of start to take over the role as acting as a reservoir for bile to hang out in. Some other things happen too, and we'll talk about those in a little bit, but we see the common bile duct start to enlarge after a cholecystectomy. So while normal is 6 millimeters, we don't consider it dilated for these groups until after 10 millimeters. So if we have a 9 millimeter post-cholecystectomy common bile duct, totally fine, no matter the age. That 9 millimeter common bile duct in an 80-year-old, also fine, totally fine. But if it's a 9 millimeter common bile duct in a 40-year-old who's having right upper quadrant pain, not okay. So it depends on their age, it depends on their gallbladder status if they have it or not, and then it depends on kind of their symptoms and what we can see. If we're starting to see dilation of the intrahepatic ducts, kind of like that picture I showed you a couple back, where we can see those intrahepatic ducts, then we're going to start to wonder, is something blocking again, causing everything to kind of backflow into the liver? So why do people get gallbladder ultrasounds? This is probably one of the most common ultrasounds you will do. Patient is suspected to have gallstones. And gallstones typically present with a right upper quadrant pain and nausea and vomiting. The gallstones cause what we call cholecystitis, which is inflammation of the gallbladder. And again, we'll learn about all of this in pathology. But that then can cause them to have a positive Murphy sign. And so again, we'll learn about it in pathology, but a positive Murphy sign is where, and we do this with ultrasound, we place the probe right underneath the rib cage, right over the gallbladder. And we ask the patient to take a big breath in. And as they take that big breath in, we're going to put some pressure down. And when that gallbladder slides underneath the pressure of our probe, and we're going to watch it slide, if they kind of catch their breath and stop breathing, that's a positive Murphy sign. That's because touching that inflamed gallbladder really hurts. So they're going to jump a little bit. That's a positive Murphy sign. Sometimes people just say, oh, it hurts over there. And it's because you're on their rib or they're being wussies about it. But back to indications. Right upper quadrant pain, probably the most common thing you will see on ultrasound orders, especially for the abdomen. Some other things that we see that are specifically related to the gallbladder is pain radiating to the right shoulder. The same nerves that go to the right shoulder also go to the gallbladder. So sometimes you get this pain that is from the gallbladder, but it gets expressed up in their shoulder. So it's kind of weird, but it happens. So that's actually a really big indicator of gallbladder disease. Liver function tests of the liver will be abnormal with some sort of gallbladder disease. And then another big one is intolerance to fatty foods. So you'll have patients say it always hurts after I eat steak. It hurts after I go to McDonald's. And that's because there's usually a lot of fats in those foods. Bile helps us to digest fats. So when the gallbladder has to work because the patient has ingested this certain amount of fat, then it starts to hurt, and then they go to the doctor because of it. All right. So pain, right upper quadrant pain, is probably our number one reason why we do abdomen ultrasounds, and it's almost always because they're concerned something's wrong with the gallbladder. That gallbladder, easy organ to learn about, but he's a tricky bugger. There's tons of pathologies that go along with it. Patient prep I've already kind of touched on. It is NPO for 68 hours. We really want that patient to be NPO if they can be. If they can't, not the end of the world. We're going to do our best regardless. Patients who are inpatient might not be able to not eat due to other medical reasons. Children, it's kind of hard to get them to be NPO for too horribly long. So if we can, 6 to 8 hours is ideal. Transducer wise, you're not really going to switch out any transducers to image the gallbladder specifically. So you can just continue to use your low frequency curvilinear transducer or your vector transducer. Most of the machines that we use currently have a broadband of 5 to 1 megahertz. So we're typically using kind of around that 2 megahertz, 1 megahertz range to image the gallbladder. Patient position is a very important concept to know with the gallbladder. We usually start the patient out on their back, and that's called supine. And then I like to have them raise their arms above their head, just kind of gets everything out of the way. So now I can scan subcostally or below the ribs, or I can scan intercostally in between the ribs to see the liver and the gallbladder. And so I take pictures of the gallbladder in supine, both in long and transverse, and then we want to roll our patient. And it might be kind of weird, why are we rolling the patient? Well, the gallbladder is really floppy, and we want to see what happens when we roll the patient. We want to see what the gallbladder does. And when the patient is on their back, their gallbladder fundus hangs more towards their feet. When we roll them onto their left side, that gallbladder fundus will kind of roll then to the left side as well. So it changes the position of the gallbladder. And when you change the position of the gallbladder, it tends to shake things up a little bit. So if the patient has those gallstones, then those are going to roll into a different area typically. If they have sludge, that'll move into a different area. Or if they have like little debris within their gallbladder, that'll kind of kick it up, and we'll be able to see that when they roll, and then we can document it. So we take pictures in the supine position and in the LLD position. LLD stands for left lateral decubitus. And when you roll your patient, make sure that you are labeling your pictures LLD. We want to show the radiologist that we did that. Now I also like to, once I roll the patient into the LLD position, I also like to kind of review the liver. Maybe I can get better pictures of that right lobe with the patient in the LLD position. So it's okay to take extra pictures, just so we make sure that we're seeing all the anatomy clearly. As far as the biliary tree protocol goes, again, you will be taking representative pictures of the gallbladder. For our purposes on campus, you just need one in long and one in trans while the patient is supine. And then you're going to roll the patient into the LLD position, and again, you'll take a long and trans picture of the gallbladder. Now the 4 of those are starred because you have the choice of these 4 to measure your gallbladder wall. You only need to measure the gallbladder wall on one of these images, and they'll go over this in lab with you. Your last pictures then that you need are of the common hepatic duct and the common bile duct. You can leave the patient rolled, or you can have them come back onto their back. It's up to you. If you remember seeing it when you were looking through the liver, absolutely have them come back onto their back, but there's nothing wrong with leaving them LLD. When you go to take pictures of the common hepatic duct and the common bile duct, you're going to look for it with the color on. Color on means that we are differentiating between the bile ducts and the other vessels like the hepatic artery or small portal veins that run with it. So your first picture is always going to have color on. We don't take a grayscale of the ducts. We take a still image with the color on. So that's our without measurement picture, color on without measurement. And then we measure AP on the inside of the walls of the duct. So make sure you're on the inside of the walls, measuring perpendicular, and then we'll take that with measurement picture. All right, so 4 pictures of the gallbladder, one of them needs a measurement, one picture of the common hepatic duct with the color on, another picture with the measurement, one picture of the common bile duct with the color on, and then another picture with the measurement, and you leave the color on when you take your measurement pictures. And last but not least, last slide guys, cholecystectomy. So cholecystectomy is basically, for lack of a better word, a cure for many gallbladder pathologies. You have a stone, let's take the gallbladder out. Cholecystitis, let's take the gallbladder out. Gallbladder's not functioning 100%, let's take the gallbladder out. A lot of people have had their gallbladders removed. So one of your very important questions that you need to ask your patients are, have you had any abdominal surgeries? And no joke, a lot of them are going to be like, nope, no abdominal surgeries. You'll get in there and you'll be like, where's your gallbladder? And they'll be like, oh, well, I had a gallstone, I think, and I think they just took the stone out. Secret, they don't ever take just the stone out. They take the whole thing out. So what I like to do is just ask my patient, have you had any abdominal surgeries? And then I confirm again, do you still have your gallbladder? And sometimes you'll catch some of those people that didn't realize that their gallbladder might be gone. Anyway, cholecystectomy, once it's gone, it does make some changes. We talked about how it makes the common bile duct a little bit bigger, and that's because a few things happen. The sphincter of Oddi gets kind of loosey-goosey, and so it no longer holds the bile back like it did when the gallbladder was there. So the common bile duct starts to enlarge and kind of holds more of the bile, because now the intra-abdominal pressure is causing that bile just to kind of free flow out of the liver. So nothing wrong with it. It functions just the same as it needs to in people who have their gallbladder. Everything is fine. It's just a little bit more free flow bile consistently. The only time you get concerned is if that bile duct gets over 10 millimeters or that 1 centimeter threshold. If a patient has had a cholecystectomy and we go to image their gallbladder, we change our protocol a little bit. We no longer, of course, take pictures of the gallbladder and the gallbladder wall because there's nothing to take pictures of. But we do take pictures, long and trans, of the gallbladder fossa. And then you do not need to take rolled pictures of the gallbladder fossa at that point. And that, my friends, brings us to the end of gallbladder anatomy and ductal anatomy and ultrasound appearance. Make sure to study your diagrams, know the common landmarks that we see by ultrasound, be able to describe things with ultrasound terms, and work through your workbook. It'll help you kind of prepare then for your exam. Let me know if you have any questions.